Hi, everybody. We're going to discuss a topic today that is very important in the breast cancer community, breast sensation. We just can't seem to talk about that topic enough and get the information out about it. It's important to me as the founder and director of Deep Sea Foundation that I not only learn about, but also understand the latest innovations to improve patient outcomes and quality of life after breast cancer surgery and a diagnosis. So, just to let you know, we're recording this for the Deep Sea Journey podcast today, but we like to repurpose them. It will also be over at the Deep Sea Foundation YouTube channel if you care to watch it. And this interview is not only for patients, but surgeons also. We want to get the word out about this. Please let us know in the comment sections of either the YouTube video or the podcast, should you have any questions that might arise from the interview today. I want to introduce my guest, who I like to call a friend, Dr. Summer Hanson, who specializes in plastic and reconstructive surgery. She's an expert in treating a wide range of conditions, offering everything from complex breast reconstruction, trunk reconstruction, and extremity reconstruction to skin cancer treatment, revision surgery, and lymphedema surgery. Dr. Hanson takes a holistic approach to care and is committed to offering each patient a personalized, comprehensive treatment plan. She works with her patients to understand their individual goals and concerns, and together they establish a plan designed to improve recovery and deliver long-term success. In addition to her clinical practice, Dr. Hanson is also devoted to research, which I'm thrilled is that's what we're going to be talking about today and focusing on. In this interview, the topic is going to be about her involvement and work with the Bionic Breast Project, and more specifically, we will talk about the FEEL project, which stands for Focus on Educating Everyone About Sensation and Loss of Pain. So, Dr. Hanson, yay, we got this on the calendar. I'm so glad to see you. How are you?
I'm doing well. I'm doing well. Thank you so much for the invitation. And thank you for continuing to invite me because I've been terrible at actually scheduling this. So I'm so glad it worked.
You know, between family, life, and oh yes, your microsurgical practice there at University of Chicago, your schedule's a little full. So all good. We did it. So I'm ready
Yeah.
to get on with this conversation. How about if we kick this off, Dr. Hanson, and can you give us for the listeners just a
Mhm.
brief summary or quick explanation of the Bionic Breast Project to start out?
Yeah. Yes. So the Bionic Breast Project refers to a multidisciplinary group and study and focus for research on trying to build a breast system that restores sensation. Um, as I learned, as I became more involved at the University of Chicago, it's not only the system or the device itself, but it also encompasses so many different aspects of education and research and design on restoring sensation after mastectomy, restoring sensation and mitigating pain or trying to reduce pain. And so the group focuses not only on the design or the building of this device, but also, as I said, different aspects of sensation and restoration after surgery. So some of that is brought up with the FEEL video, which we'll talk about. And some of it is brought up in just considerations before and after mastectomy, or as patients are thinking about risk reducing mastectomy. And then the experience that they've gone through, specifically focusing on sensation and embodiment. The bionic breast device, or the bionic breast study itself, is looking at building a system that will essentially restore sensation, but in a different way than our current techniques. So it's actually a bioprosthetic that is very similar to the concepts in bionics and bioprosthetics that are used for amputation reconstruction and prosthetics. So kind of connecting nerves to the device. And it's a system that has electrodes that are attached to the nerves that are cut during the mastectomy surgery. And then those electrodes then will connect to a flexible sensor that can sit under the surface of the skin of the breast pocket. And essentially, at the time of the mastectomy, when that system or that circuit is cut with the breast being removed, we're just restoring it right then and there. So there's no real like healing or dependency on the nerves to regenerate. We're just swapping out a nerve for an electrode, just like you would swap out, a breast for a tissue expander or a breast for a flap. And I don't mean to sound crude when I say that. It's just kind of conceptually that's how we're thinking about it, because our current techniques usually require a nerve graft or suturing nerves to each other and dependent on them growing and reconnecting or reestablishing that circuit. And what we're trying to do is just put it back into continuity. There's as many phases as you can imagine.
Yeah, that's what I'm thinking of right now. So you had really the team involved. You had to, of course, have the engineers who are going to design the circuitry, so to speak, the device, and then kind of marry that with the knowledge of the microsurgery part of it to understand how to best, make all the parts work together.
Mm-hmm.
Yeah.
Yeah, and Stacy Lindo, who I know you've spoken with, who's kind of our lead PI, has this amazing ability to find the right people and put them in a room together and just spit ideas. And so she and the other primary investigator, when I came on board, Celine and Ben Smea, were kind of putting all those pieces together. And then she reached out to me like within my first couple of months on campus at U Chicago, and it was COVID, so I hadn't really met anybody yet. And she was like, "I hear you're an engineer, but also like a reconstructive surgeon." And she's like, I think you would be interested in this." And she's like, "Do you want to come meet?" And that kind of kicked it all off. So we have a team that has, psychologists and sexual health experts and electrical engineers and neural engineers and I'm biomedical engineering, and then there's another like more focused materials-based scientists, and then we have breast surgeons and microsurgeons, and so it's a really huge group, but it's so fun to bring everybody's perspective together, and it certainly strengthened the project. I mean, I think having all of those different people weigh in, but really with a common goal of trying to build a better breast, trying to improve these outcomes, is really special.
Wow. I did not know that. I remember when you moved to Chicago and it was during COVID. I didn't realize that you guys had connected, it's hard to believe we're saying, back in the time of COVID, but we are now. So
Yeah.
now, I mean, you kind of gave us an overview of what the aim of the Bionic Breast Project is. Let's kind of segue. Tell us about the feel portion of that. You are going to speak to that better. I don't even want to get into it because I have seen what you're doing. So tell us about that and how that relates to the Bionic Breast Project, because the way I see it, Dr. Hanson, you just talked about a huge team that's working on that. There's another missing piece. That's the field project in my mind.
Yes.
Tell us about it.
So I think so I'm very excited for what the bionic breast can do, but I think so far the best thing that's come out of this study group and this research is the field project or the field video, because we started by putting together these grant applications and writing up these protocols on why we need to apply bionics to the breast, to mastectomy, and thinking about how many, hundreds to hundreds of thousands of amputees there are versus how many, hundreds of thousands to millions of women there are who have undergone cancer treatment. And some of the feedback that we would get on these applications were like, well, but is this really important? It's just the breast. And obviously it was a little bit more tactful the way that it was delivered, but that's the underlying message. It's like, it's just the breast. So then we were like, well, we need to, it's easy for me to say, yes, of course, this is important. We need patients who have experienced this to understand what it is. And so as we were kind of going through and learning from patients what their mastectomy and their loss of sensation or their long-term pain or their, chronic immobility or discomfort with the chest, what that meant, that evolved into, we really need to like teach people how to talk about this. And myself included, I would talk to patients about, you may have some changes in sensation, or you may not be able to feel the same way that you do now, and kind of leave it at that. And a lot of times patients don't think to ask more on that because they're still processing the cancer diagnosis and they're still processing all the other parts about this. And then you don't find out until after the fact, like how impactful that really is. And so now we talk about, these nerves will be cut most of the time. Sometimes we can restore them, but not always. And for some patients, that means pain. For some patients, that means tingling. For some patients, that means just this sort of cold,
numbness.
like just strange feeling. Yeah, it doesn't feel like them.
Yeah.
And so we go through all of that information now, and it does obviously add to the conversation. And I have patients kind of direct what they want to hear or what they want to know about. But I think that was a really, really big part of learning more about this. So again, Stacy, Dr. Lindau and her team put together this video that was sponsored by the women's group at the University of Chicago. It was funded by the group here, and it's, it interviews with patients who have undergone different types of cancer treatment, type of cancer surgery, different types of reconstruction, in some cases no reconstruction and just flat closure. And then those of us that are part of the project and part of the study group, and how we engage with patients.
That's such a good collaborative group. So missing piece was the patients, is where I was going with
Yes,
that. And
absolutely.
I love it because, what you're really talking about, from my perspective, and what I always like, it's part of why Deep Sea Foundation provides the resources that they do, is sometimes patients don't know what to ask. They don't know the vocabulary. And I think that that's what the Field Project does. When they hear other patients and they're like, and they connect with them and they're like, that's what I was feeling, or I didn't know that was going to happen. And now I can ask my surgeon about it or be concerned about it before, they have their surgery at a consult, or, even after. What do we do about it now? You brought up a term that I'd like for you to speak a little bit more about. And I was reading it actually on the website. It's, it's something I think many of us have experienced, but maybe we're not familiar with the term, and it's disembodiment.
Mm-hmm.
You talk about that a little bit?
Yeah. I mean, I'm sure there are people that can speak to this better than I can, but it's essentially just that it doesn't feel like it's your own. It's part of you, in terms of the reconstruction, or patients who have limb loss, or any type of physical change like that. We feel that embodiment is very much a part of kind of feeling normal or whole again after this type of surgery. And again, whether it's trauma or reconstruction or anything like that. And there's a lot of that doesn't happen when you don't have that sensation. And this has been a focus quite a bit for amputees, and for trying to restore function and sensation in prosthetic limbs. And only recently have we started to promote this more within breast reconstruction and post mastectomy surgeries. And I think that it's a very common thing that I heard now, after, as I kind of bring it up more in patients who have already had their reconstruction, and we weren't able to do anything from a nerve or sensory standpoint, or even if we are, and they're just not getting the same type of sensation back that I think we were hoping for. That's a hard part of it, is that they say it just doesn't feel like me. It's there, it doesn't hurt, but it doesn't feel like me. And I think that's,
It's the mind-body connection, isn't it?
yes.
Yeah. And so Dr. Hanson, you do uh, a number of different reconstructive surgeries. And we were
Mhm.
talking offline about, you know, if a nervous cut, like if you work on a hand, a nervous cut,
Right.
people think just because you use your hand more, maybe it's more important to focus on that than the breast. But I have to tell you, I have told people this before. When I had my mastectomy and I was left numb, I actually went to my breast surgeon for my follow-up, a couple of weeks afterwards. And I go, why am I stumbling? Why am I tripping? It's
Yeah.
that, yeah, you can speak to that, right?
Yeah.
With
I
your
mean,
patient. That's, to me, that's the
yeah.
disembodiment. It's,
Right.
these things are quality of life for breast cancer patients too.
Yeah. Oh, absolutely. And I mean, it might sound silly to say, but the breasts give you a sense of where you are in space as
Yes.
well, right? And if you all of a sudden have, this much of your body that's no longer there, you have a complete imbalance in your shoulder girdle. Even if you have both sides, the the way that your body was in space, or the way that your tissue, sat in space, and how you perceived yourself relative to your environment is now different.
Mm-hmm.
And like I said, it may not hurt, it may not, but it's different. It's there. And that, in your case was stumbling, but that's definitely something that patients have to get used to, or at least should be warned about.
Yes, and those are things that you don't expect to adapt to or to experience. I
Right.
certainly didn't. And to be clear, I didn't have, large breast before my
Yeah.
mastectomy. It doesn't take a large breast to feel that disembodiment. So
Right.
I'm really glad that you answered that question for me and kind of went into that a little bit in more detail. Okay, so I think I there's so much we could talk about this project, but one thing I do want to mention before I forget it in our conversation, I want people to know that there's many avenues that they can find out about the Bionic Breast Project and the Feel Project. Can you speak to us a little bit about that?
Yeah, I think that there are we'll have links to the different sites through the podcast and through the YouTube channel. And I know your group has been excellent about trying to disseminate some of this work.
Mhm.
Even if you just Google search Bionic Breast or University of Chicago Bionic Breast or FEEL, FEEL, even though it's a long acronym for for FEEL,
Yeah.
that will come up. That will give you links to all of that. Another kind of broader resources, the Woman Lab at the University of Chicago as well. And those are all different resources depending on kind of what you're interested in or what you're looking for. I think one thing that I will just highlight too is if you are listening and you're, wherever you are in this journey, or this uh, uh, group of either researchers or students or surgeons or patients or family members or caregivers, we really actually value your feedback on the video itself. As I said, that evolved from feedback about grants and then feedback from patients, and then we created this video, but we want to do something that's meaningful, and so it is out there. Obviously we can't take it back. But we can certainly revise different iterations, and if there are things that we haven't discussed or topics we haven't hit on, or if there's something that anyone feels like we could cover better or we haven't addressed, or if you like it, even better. But having that feedback on what we've created, I think would be very beneficial to the group.
Yeah, and please, for the listeners, again, like Dr. Hanson said, this is not just for patients. The aim is to gather community together to give feedback. So if you're listening to this, the podcast, feel free to share your comments. YouTube channel, I keep an eye on those. If I can't answer it, I know who to go to. So I will let them know. And Dr. Hanson mentioned too Deep Sea Foundation, part of our work, we have a private Facebook group called Deep Sea Journey Breast Reconstruction After Mastectomy. And for those members who are listening, we do have the FEEL project pinned to the top of the journey. So if you're newly diagnosed, this is for patients, to be clear. But if you're newly diagnosed, whether you have a genetic mutation, if you're newly diagnosed, if you're thinking about reconstruction, feel free to join that group. You will be asked to answer a couple of questions, but that's another way that you can find out about the FEEL project. And I really am grateful that you guys have allowed us to help you out with that. So a big thank you to both you and Dr. Lindow for reaching out to me on that. What else are we missing? Like 100 things, but what else do you want to share? Are there any updates? Are there any recent updates that we need to know about?
So the Bionic Breast Project, as I said, was multiple phases. We have FDA IND approval and IRB approval for patients for the phase 0 safety and feasibility study. That is essentially the first part of this system in which we connect the electrodes to the intercostal nerves that have been cut during the mastectomy surgery, and then we're actually bringing patients in who have the device implanted. Just the electrode part is implanted, and then we're actually stimulating those nerves and trying to see what sort of sensation we can gauge out of them. There's a lot of information, again, in limb amputations on how much signal you get and where you can trigger feedback on pain versus touch versus temperature. None of that is really known about the chest wall, and so we're kind of going through that process now. At the same time, in the lab, we're building the flexible sensor that is going through preclinical testing right now. So it'll be a while before this is all put together, but we've already started enrolling patients. We've gone through the simulation process, so it's all very encouraging. Anybody who's interested in learning more or interested in participating, certainly you can reach out to me through the University of Chicago or through the Bionic Breast site. What else can I tell you? We have other projects going on, research going on in the lab, just in terms of engineering and reconstruction. So there's plenty of fun new things happening.
That's really exciting. Can I ask you a question? Because I have a feeling some people that are listening, patients specifically, are going to wonder. You're talking about electrodes. What size are we talking about that's implantable within the breast to test these nerves?
Yeah, so the intercostal nerves are anywhere from 1 to 2 millimeters in diameter, so pretty tiny. And then the cuff just wraps around that. It's funny, again, as I said, Stacy brought a bunch of different people together, and so the engineers that initially developed these cuffs for these big cord-like nerves in the arm were showing me these, and I was like, there is absolutely no way that's going to fit on any of these nerves. Like, you need to scale that down about 10 times smaller. And it wasn't until we were actually did cadaver dissections and clinical applications that they realized just how small these are. And so when I first was trying to explain to them, I used a coupler device. I don't know how much you guys have talked about couplers for vein connection and microsurgery anastomosis for our
You can
flaps.
tell us about them in a second, but keep rolling.
But I basically said, this is what we have to, I want it to look just like this, essentially.
Yeah.
And they're like, how do you even see that? And I was like, well, I have loops and a microscope. And
yes, you're talking to the person who looks at those things and knows what the size needs to be. Yeah, the coupler is a connecting device, but go ahead and talk to them more about that, because some might want to know what that is. I think they probably hear that term, but don't often know what it is, patients specifically.
mm-hmm. Yeah, the coupler device is actually, oh, I just hit my desk. The coupler device is essentially a tube that you can connect, you can use to connect blood vessels. So we typically use them for veins. If it's small enough, you could use it for an artery or for a lymphatic channel. But it essentially is a little stylastic tube that then the ends of the vessels go through, and you use it to kind of bring them together, and it keeps that anastomosis, or that new blood vessel connection, open. And we find that for veins especially, it's helpful rather than with the arteries, we have to sew them together. And so the coupler reduces time a little bit, and and it helps to keep a set diameter for the vein connection.
Mm-hmm. Yeah. So many tools you guys have to use. And so this one, another question I thought of. Um,
Mhm.
you know, we have done videos and interviews on nerve reconstruction, on nerve preservation, and we know that nerves grow back together at a rather slow pace, and patients can't expect, I always tell them they can't expect to wake up with sensation. Is this speeding up that process at all?
So in theory, it should,
That's what I'm
because
thinking.
right, right. So we haven't gotten to the full system implanted yet,
Yeah.
but ultimately, what it'll be is instead of if you find it, so in our current practice, if you find the cut end of a nerve
Mhm.
and you have either your breast flap with a small nerve that you can just connect right then and there's a little bit of time for that to grow back to the nerve to grow along that other nerve to connect to the flap.
Mhm.
Or we use a graft that goes, up to the nipple around an implant. And it takes a very, very long time for all of that to happen.
Yep.
And here with the bionic system, that cut nerve isn't going to grow anywhere else. It's now going to be wrapped with an electrode that then the wire goes right to the skin flap or to the nipple complex. So as soon
Yeah.
as you push on that, it's going to signal back to that nerve, back up to your brain.
So to me, this is the process of perfecting this final product, really. This is one step.
Yes.
Yeah,
Yes.
gotcha. Okay.
Yeah.
You know what I love about conversations like this, Dr. Hanson, is that, you know, this patients have to understand that projects like these take time, they take revenue, they take a team. But here's what I get excited about, knowing that it's in development and I
Hmm.
can stay in touch with you. We can do more videos as things, progress along, and just getting the word out about this, not only to patients but to surgeons, to new trainees. They need to know about this. It's a very important topic to patients, I can tell you. So,
Yes.
hey, we did it. Thanks for joining me today. And we look forward to getting this published so that we can share it. And thank you for, taking this on and taking interest in this to improve patient outcomes. From all the patients that I experience and talk to in the community of breast cancer and breast reconstruction, I'm just going to give you a big thank you and shout out for doing this. We appreciate it.
Well, thank you. Thank you again for having me on. And I mean, the work that you do is remarkable. And so I thank you for all of the advocacy and education that you do because, it really helps to get out what we're doing and what we're trying to improve and trying to build. And I think that it's really exciting to be able to partner with the patients and do something meaningful like this.
Well, thank you very much. I think we all follow our calling and enjoy it. And it's good to know people like you who do the same. I love the work that I'm doing. It's very apparent that you do too, Dr. Hanson. So thanks a lot.
Yeah.
Great to see you.
Thank you.
Uh-huh.
You too.